Hello?
Yes, Dr. Kafali.
Yes, Samar?
Yeah, Isam.
Okay. መጀመር እንችላለን?
በእኔ ሳይድ ሬዲ ነው።
ግሩፕ ሬዲ ከሆነ you can tell me, go ahead.
I think አቶ ጌትነት will tell us, yeah.
Okay.
Dr. Cafe, you can start. It is high time.
Okay. Thank you, Ato Getinnet. It is a pleasure for me to be here for 60th annual and international exhibition of EMA. And this semi is presented by EMA with Ethiopian Society of Cardiac Professional Society in collaboration. So our today's topic will be what's new in acute coronary syndrome. That will be presented by Dr. Demu. I am Kafele, a cardiologist, interventional. Currently, I'm serving as Ethiopian Cardiac Professional President. Dr. Demu, it is a pleasure for me to introduce him. He has done his undergraduate at Jimma University, then later joined at Sabah University for his internal medicine, and finally also did his fellowship in adult cardiology at Sabah University. And he had one of the best students in all his academic career. And I have seen him during his fellowship training. He was very good understanding clinician and to the patient point, and currently working at Adama Hospital at Adama Medical College as cardiologist, and they're doing very nice thing for undergraduates, postgraduates, residency. And this is a very big thing that most of we including me, we are considering Addis. He's doing it out of Addis. That is a big plus for our society. I really appreciate that you and others who are doing out of Addis. So acute coronary syndrome, it is our incoming big way coming burden for the country, because we are there to be in double burden, but now it's most of look like NCD coming on top. That has an emergency and high mortality, and this is high time to discuss about the update on acute coronary syndrome. And for this, Dr. Demu is an appropriate person we selected through society. Please, Dr. Demu, this is your time. You can go ahead. And for audience, there is chat box. You can put your questions there. Later at the end, we can entertain. And there is a question at the end, just like a question, which will have a grade. You should have a score 50% to get your grade points. So this is to catch you to attentive. Thank you, everyone.
Thank you, Dr. Kafaling, for a really generous introduction. It's my pleasure to be with you, my teacher. In fact, I believe you'd have presented this case, but it's my pleasure to be with you on this stage, actually. Thank you very much for your generous introduction.
Thank you.
So I think if there is no pre-test questions, we can proceed with the presentation probably.
Yeah, go for presentation. Then we have the question in the chat box. Finally, we can entertain.
Yeah, thank you. Okay. Let's proceed to, I think the slide is with Ato Getina, so allow me to the next page. Thank you. As earlier presented, it's one of very common condition that we really encounter. So my today's presentation will be, I'll try to go through according to this outline, the definition, the management and antithrombotic, mainly focusing on antithrombotic revascularization, secondary prevention, and lastly, we'll have a discussion about the presentation. Next. So, as you all know, acute coronary syndrome is a condition which encompasses of a spectrum of condition where a patient presenting with new onset of clinical symptoms and signs with consideration of 12 lead ECG with presence of cardiac troponins. So any condition that can sign symptoms even in the absence of ECG finding or troponin, raised troponin should be considered acute coronary syndrome. So the clinical presentation is basically very broad range. Symptoms could be present at the time. Patient could have the most common chest discomfort or pain could be there, or patient could present with cardiac arrest because of electrical abnormality, hemodynamic instability could be there. So the definition is a bit very broad. So when you take acute coronary syndrome, as we have earlier said, it's a spectrum, starting from more milder form of unstable angina to the more serious form, STEMI, ST segment elevation MI, and in between non-STEMI or non-ST segment elevation MI. This is a very broad definition of acute coronary syndrome. So as you know, the mechanistic underlying of acute coronary syndrome, basically an oxygen demand supply mismatch that leads to myocardial necrosis. In more than 90% of cases, it is atherosclerotic plaque rupture or erosion, resulting in superimposed coronary thrombosis. And in about 10% of cases, it could be non-atherosclerotic causes of atherosclerosis can result in acute coronary syndrome. So based on the series of revisions of universal definition of EMMA, as you know, MI definition has been, different societies have been considering myocardial infarction as a different, definition has been different across different cardiology societies. But in early 2000, so different societies came together and put forward a definition of universal definition of MI. Subsequently, it was revised 3 times, and now the last fourth definition of MI had been put forward in 2018. So based on that, there should be, according to definition of MI, there should be a clinical symptoms suggestive of ischemia with acute rise and fall of troponin, and the rise or fall of troponin should be more than 99%. So based on the degree of occlusion of arteries at the time of the presentation, ECG finding would classify them into ST segment elevation and non-ST segment elevation MI. ST segment elevation, in more than 90% of cases, it's an acute occlusion, complete total occlusion of infarct artery, whereas the non-ST segment elevation usually partially occlusion and unstable angina is when there is oxygen mismatch, oxygen demand and supply mismatch. So depending on the time of ischemia, as the time of ischemia passes, you know, the degree of necrosis can extend from subendocardial to transmural extent, depending on the time of, as the time goes, the necrosis will go next. So microscopically, when there is a coronary occlusion, so it starts from within a second to minutes. So there will be a glycogen storage depletion within a minute, and resulting into impairment of cardiac myocardial functions like sarcolemma disruption. And as the time goes, necrosis progresses in extent of extent. So this infarction depends on the time of on the presence of collaterals. There are some other determinants like oxygen consumption, intermittent occlusion in the previous, and reperfusion with preconditioning previously would determine the extent of the extension of ischemic injury. This is just summary of what has been said, starting from the seconds of occlusion. ATP starts to deplete, and when as time passes, patient will have microvascular injury when the occlusion stays for more than 1 hour. So the two terminologies, myocardial injury and myocardial infarctions, have been it's used interchangeably, but according to universal definition has been forwarded, any elevation of cardiac troponin above 99 percentile is considered as with myocardial troponins greater than 19 above the normal percentile is said to be myocardial injury. So this myocardial injury could be a lot of conditions, but not necessarily myocardial ischemia. Myocardial ischemia is when there is a clinical suspicion, clinical presence of ischemia with cardiac troponin. Myocardial injury is said to be myocardial infarction. So there are so many conditions that can result in rise or fall of cardiac troponins, like stretch or heart failure, or any non-cardiac condition can also result in red troponin. So not necessarily rise in troponin doesn't mean necessarily myocardial infarction. So this is just to show so many causes of myocardial injury: anemia, ventricular tachycardia, kidney diseases, and heart failure can cause cardiac troponin rise. So as been forwarded by universal definition, so a rise and a fall cardiac troponin above 99 percentile with at least one of the following is said to be myocardial infarction. Presence of sign symptoms of myocardial ischemia that are demonstrated by clinical symptoms like chest pain and chest pain equivalent, ECG changes, development of pathologic Q wave, or on imaging if there are any regional abnormalities or coronary angiography showing coronary thrombus. So based on these definitions, there are 5 classes of MI types. The most common one, the atherosclerotic types, type 1. And so when do we suspect a patient acute coronary syndrome? So the most common complaint that we know that is chest discomfort, about 80% of cases. There are also conditions. Am I audible?
Yes.
There are conditions that we need to consider as chest pain equivalent. Most of the time in females, we encounter patient having dyspepsia being treated as a dyspeptic patient with PPI and with different kinds of antacids, but later on found to be MI patient. But we need to have a high index of suspicion. These are said to be dyspepsia, epigastric pain, pain in the left or right shoulder, jaw, neck pains are said to be equivalent to chest pain discomfort or chest pain secondary to ischemia. So the other one are altered mental status, particularly elderly patients. When they may not complain about chest pain. The other one is hypotension, particularly patients who undergone procedure, non-cardiac surgery, who have unexplained hypotension, new onset of arrhythmias. Elderly or patient with risk factor having new onset of arrhythmia should be suspected as having acute coronary syndrome, unless otherwise ruled out. So extreme fatigue and sudden onset of fatigue are commonly one of the features that patient presenting with acute coronary syndrome. So it's not more necessarily chest pain. So as we all know, the typical chest pain ischemic origin is said to be retrosternal pressure type tightness with a central type of chest pain. But this is said to be having high index of probability for secondary to acute myocardial infarction. But whereas those pain, more sharp, fleeting type with positional change is said to be less likely to be origin of ischemia. But in the presence of, particularly in the presence of risk factors, patient with atypical signs of chest pain or chest pain equivalent should be suspected to have acute coronary syndrome until ruled otherwise. So the common symptoms, both in females, the study showed that 80% of patients complain chest pain, retroabdominal type of chest pain, both equally in females and males, whereas some of the symptoms are common in females, particularly dizziness. Next, so dizziness, 3 other symptoms like diaphoresis, epigastric pain, shoulder pains are said to be commonly found in both females and males. Is that possible to pass? So some symptoms are common in females, particularly dizziness. Elderly, diabetic patients, females could have atypical symptoms like change in mentation. I think pass next. Elderly patient likely present with atypical symptoms with shortness or pre-syncope, change in mentation. Particularly female should have high when we encounter we should suspect high index of suspicion. So the clinical presentation of, as we have said, patient might sometimes may not have any symptoms, particularly perioperative MR. So because of they might have been on analgesics or maybe because of sedatives, patient may not have clinical symptoms. But some patients might present with cardiac arrest. Some patients might present with heart failure, cardiogenic shock. So the clinical presentation of acute coronary syndrome is very wide and very. So we need to have high index of suspicion for acute coronary syndrome. So the clinical presentation may not necessarily of chest pain. So there are high factors which led diagnosis of MI, particularly STEMI. So particularly, patient may not have recognition about heart attack. So they might have minimized perceived risk of cardiac disease, particularly youngers might perceive that they may not have a cardiac or heart attack. So in the absence of even the absence of common conventional risk factors, so they perceive that they may not have a cardiac disease or acute coronary syndrome. So the other one is particularly system delay. Physician side, lack of experience, particularly in interpreting ECG, and also consideration of atypical symptoms, lack of information about heart attack, lack of adequate infrastructure once the patient has been diagnosed, and the availability of also infrastructures would delay in others. So very important to early diagnose clinical suspicion. Clinical high index of suspicion would impact the patient management and also outcome. So the ischemic times is very important to minimize. So there are so many factors: patient side, physician side, and from the system side would result in ischemic time, which affects the prognosis and outcome of the patient. So not all chest pains are of ischemic origin. So we need to have also other differential should be taken into account, particularly aortic dissection, PE, which are very common nowadays, and valvular heart disease and other common conditions of lung origin and musculoskeletal conditions should also be taken into consideration. But the most important serious condition, aortic dissection, PE, pneumothorax, and acute coronary syndromes are the things that should be ruled out in someone presenting with chest pain. So epidemiologically, there are no much studies. There are few studies in our setup, as you know, and most of them are hospital-based or institutional-based. But in the worldwide, acute coronary syndrome is one of the major problem, and we are also noticing nowadays is a very common problem in each of our practice areas. But if you take in one of the developed countries in America, 1.5 million people are said to be diagnosed yearly as an acute coronary syndrome. despite there are well awareness and also improved care of STEMI patient, the days has been decreased, but as well as also STEMI has been declined, but the other part of non-STEMI said to be rising in the western side. In our setup, in the western side, at around 20 to 30% of acute coronary syndromes are said to be STEMI, but in our setup, in some institutional-based study shows more than 50% of acute coronary syndromes are STEMIs. So so STEMI care has been over the last 30, 40 years, the STEMI life survival have improved because of different implementation of guidelines like reperfusion, antiplatelets, anticoagulant, the fibrinolytics, and the PCI have been implemented, and medical care has been improved. So mortality in the early hospital mortality as well as 1 year mortality has declined, as been shown in the Kaplan's Mayer, as you can see from in the western side. So I think so. So when do we encounter? So in the patient with AS, we might encounter in community. So in emergency department, probably in regular OPD situations, patient with peri procedure, particularly non-cardiac surgeries, might patient. So it is very important, and it can't be emphasized that proper history taking, physical examination, and high index of suspicion of acute coronary syndrome should be taken into account in all our medical practice. So the first thing for after suspicion of acute coronary is the most important thing to look is ECG. ECG is a very important tool to make a diagnosis of acute coronary syndrome. So the first thing that we need to do is if there is any abnormal ECG or not, particularly focusing on ST segment elevation. Okay, that's a very important. The clinical situation of the patient, whether the patient is stable or not, we need to take into consideration. So subsequent management, subsequent physical examination should pursue as depending on the ECG finding. The most important thing, one, is to rule out STEMI at the first contact within 10 minutes of encounter. This is ideally in hospital setup. The other is focused physical examination, particularly looking into the vital signs, just major arteries, auscultation of heart and lung. Just brief cardiovascular examination should be conducted, even though not exhaustive. Next. So based on the ECG finding, how do we define ST segment elevation at J points? So for a male, depending on the age, it has to be for age less than 40 years. So on V2 and V3, more than 2.5 millimeter or equal to 2.5 rise of ST segment is considered as STEMI. For more older people or for more than 40 years, I don't mean so more than 40 years, it's the cutoff point is less than the previous one, 2 point. For females, the lower threshold should be considered 1.25 for women. So because that's why this is because there is a male type of pattern ST segment elevation like repolarization and likes ST segment elevations are common, particularly in V2 and V3. For the rest of the ECG leads, the cutoff point is more than or 1 millimeter in the absence of LVH or LBB or pace rhythm. So if there is an increment, if there is a rise of 1 millimeter, we need to consider this is ST segment elevation. For the same thing is true for the side for the right side of ECG, but for the posterior side, we will consider as ST segment elevation if it is more than 0 or more than 0.5. But for the right side, the same as other 1 millimeter. For posterior, it is 0.5. So the J point is the junction at which ST segment and QRS meets. So the isoelectric line is said to be the TP or the PR segment. So the criteria is we use this as the isoelectric, and then any rise here will be considered as segment elevations. The previous concave is nowadays is not much appreciated. So the posterior ones, not all depression, ST depressions are said to be ST depression, non-STEMI, but some patients like in the V1 and the V3, if there is SC segment depression, we need to suspect posterior STEMI. So we need to do the posterior ECG, which should be done by display taking V4, V5, V6, and to be done on the posterior side. So this is equivalent to SC segment elevation, the posterior STEMI. So it is very important to make STEMI versus non-STEMI in terms of management and outcome. So we need to do the posterior side. So when to do the right side or posterior? So when there is a clinical suspicion of ongoing ischemia with inconclusive ECG finding. So the posterior side and right side ECG should be done when the 12 standard leads ECG is not conclusive. So the other one is this is to show the posterior one ECG. As you can see, posterior V7, V6 from V7 to V9, and on the posterior side, where it suggests of left circumflex movement and RV infarction. So it's very important. But in the standard lead, it shows it's just a segment depression. So the managements are quite different. As you know, reperfusion is not recommended unless the patient has some clear indication in non-STEMI. But reperfusion, immediate reperfusion is very important for someone with STEMI. So it's very important to differentiate whether this is really STEMI, real STEMI, or just because most of the time the posterior and right side are electrically silent and they may not demonstrate on the standard ECG. So we need to practice doing right side ECG. So the same thing is true for ST segment depression, particularly if it's seen in more than six ECG leads. ST depression more than 1 millimeter, it's equivalent to ST segment lead. So this is very important. So if there are ST segment depression in more than 6, and particularly we need to look into the AVR and the V1. So it portends a very serious complication, particularly whether this is left main obstruction or multivessel disease. So these patients are basically should undergo invasive angiography as soon as possible. So we should not disregard SC segment widespread SC segment depression. So we need to look into also other silent areas like V1 and AVR should be looked into. So the other one of the changes that has been recently introduced in acute coronary syndrome and ST segment elevation is the presence of new onset LBB. We don't know most of the time whether the patient come with the first time for ECG with LBB, but if there is a clinical suspicion of ischemia, patient complaining chest pain with evidence of LBB, we don't know whether this is new or old. So the recommendation is basically to consider this patient as a new onset LBB, and this patient should be treated as a case of SCC segment elevation MI. And the other that we really disregard is RBB. A patient with RBB. So the same thing is true as LBB. So usually we disregard patient with a new onset. We don't know most of the time our patients came with ECG current. When we take ECGs, they have RBB pattern with R small, RS small, RS pattern. with T-wave inversion. Usually we treat like this is RBB, but these patients are particularly, they are patient with STEMI. So most of the time, this is perforator branch of septal perforator is said to be obstructed. So this patient should be treated as STEMI patient. So they have to undergo angiography as soon as possible and treated as STEMI patients. So we should not discard the two RBBs and LBBs. The next one is non-STEMI acute coronary syndrome. So non-STEMI are based on the ECG, the transient ST segment elevation. ST segment elevation persisting for less than 20 minutes are said to be transient. Persistent or transient ST depression and abnormalities on T-wave, either hyperacute or T-wave inversion, biphasic, flat, or sometimes even patient might have a normal ECG. So those patients with a clinical suspicion of ischemia and similar ECG or such features of ECG finding should be treated as non-ST segment elevation acute coronary syndrome. So the findings are depending on the different types of ST segment depressions. So particularly if the ST segment depression is in the AVL or lateral, these are said to be patients with mild impaired prognosis, whereas those with T-wave inversion in the more than one leads, in particularly in V1 and the V2, are said to be having very serious ischemia. So we should take into consideration these patients are having severe ischemia and probably they might be subjected for angiography. The other very common condition that I have encountered in one of my practices is the Whelan syndrome, the Whelan signs, T-wave inversion in V1 to V1, deep T-wave inversion, particularly in type B Whelan. These patients are said to have a very significant LD occlusion, severe stenosis. So these patients, they have chest pain, troponin are usually negative. So, but we usually disregard them as like, unless we have an experience. So T-wave inversion in V1 to V3 should be seriously seen, and these patients are benefit from invasive angiography and revascularization. This is what we call Whelan syndrome. The other form is De Winters syndrome or PSI, where V from precordial leads showing with SC segment. SC segment is like slopey type, so we need to have also high index of suspicion for proximal LAD obstruction. So not necessarily patient may not have. These patients are almost, they are as equivalent to ST segment. They don't have troponin raised. Troponins are not raised, but they are patients with serious proximal LAD occlusion, so they deserve us for angiography. Next. So some patient with, so most of the time, patient with a non-ST segment elevations do not have complete occlusion, but around said to be 1/4 of them, like patient with Whelan's, De Winters, they are said to have a complete occlusion of coronary artery occlusion. So the very important one, STEM equivalent, what is new concept? So STEM equivalent are terminal positive T wave depression with terminal positive T waves in V1 into V2 are said to be as STEM equivalent, and LBB with evidence of ongoing ischemia, RBB with ongoing ischemia, and pace rhythm with evidence of chest pain or ongoing ischemia should be treated as patient with STEMI. The previous Garbosa criteria are said to be specific, but they are very less sensitive. The newly introduced, there is what we call Smith-Garbosa criteria, but it is better to consider LBB and RBBs as STEMI if there is an ongoing ischemia in such patients. This is one of the new concepts. So how much are we right when we consider LBB as acute coronary syndrome or ST segment elevation? So LBB said to be like around 10% of patients with MI present with LBB, either new or old. So one of the study has shown that patients who have LBB and so the ST segment elevation protocol was initiated. Around 1/3 of patients have acute coronary syndrome, whereas 1/3 of them have cardiac cause like hypertension, heart disease, acute heart failure, but around 1/4 of said to be from non-cardiac conditions. So, though consideration of LBB as acute coronary syndrome may not be right always, but it is better to err on the safety of the patient rather than ignoring LBB in the presence of clinical symptoms. So it's nowadays LBB with clinical symptoms is said to be should be considered STEMI. I clinically in my clinical experience I encounter a lot of patients with LBB, but I take into consideration of clinical signs symptoms. You know, angiography is not widely available, and most of the patients cannot afford. We try to considering their clinical background, risk factors, we treat as if they have a clinical risk factors, chest pain, we treat as acute coronary syndrome or coronary artery disease. But it's better to subject them to coronary angiography if there is a doubt. So the airless, the one who I have said, this is the new Smith modified Barbosa criteria. So the previous uses different grading system, but this is more said to be sensitive, and the specificity is said to be equivalent to Barbosa criteria. So we'll consider concordant density elevation if it is more than 1 millimeter in one or more than leads can be considered as ST segment, and concordant ST depression 1 greater than 1 millimeter in particularly in the first V1 to V3 should be considered as STEMI. Otherwise, the previous, more than 5 millimeter have been just by convention. There was no study. Otherwise, the new one is if there is disproportionate ST segment elevation greater than 25% of the depth of preceding ST wave, we need to consider as ST segment elevation in LBB. So when we look into one of the ECG with, as you can see in AVL, there is a concordant, as you know, with QRS complex. So the ST segment elevation, there is ST segment elevation. This patient undergone angiography, and it shows there is a lateral circumflex was involved for this patient. So it's very important to look into some of the subtle findings in LBB for the presence of. So diagnostic approach, we know already ECG is very important for dichotomizing patient into ST segment and non-ST segment elevation. The other one is high-sensitive cardiac troponin, particularly for non-STEMI. So the rapid 0 hour and 1 hour is the preferred gold standard. If 1 hour, if 0 hours is negative, and the patient have a clinical signs, maybe we will repeat for 1 hour. But if the patient presented after 3 hours of chest pain onset, so it can almost exclude the presence of acute coronary syndrome, non-STEMI. So 1 hour and 2 hours should be used. This is an assay specific. So we have to use normal number, not decimal number. Nowadays, common practice in this is using decimal numbers. So it should be reported in nanogram per liter, and it should not be decimal. Actually, the number should be like reported in. It's non-decimal should be reported, not in decimal rather. So depending on the different parameters like Siemens, Roche, Abbott, and it depends on the cutoff points for is depending on assay dependence. So this rule-in and rule-outs for non-STEMI has a very good positive, negative predictive value, as well as also positive predictive value. So when we have suspicion and when the 1 hour, 0 hour, and 1 hour are turned out to be non-diagnostic, we can confidently rule out in majority of the patients. So you can pass this one. So for non-STEM, for STEMI, we don't need to we don't need to wait for troponin outcome. So troponin takes, like, if it is taken immediately, it will take around 1 hour. So we should subject the patient to invasive angiography without waiting for troponin result. But this is for non-STEMI patients. This is for non-STEMI patients. Okay. So the other biomarkers like double test of CKMB are not recommended nowadays, even though we see now troponin as well as CKMB are being done for the sake of reinfarction and the likes. We can use troponin, like for reinfarction. The current definition is raise or increment of more than 20% is said to be as reinfarction. So it's not recommended to do CKMB in addition to cardiac troponin. So cardiac troponin I or T can be used. So in a patient with renal impairment, we can use cardiac troponin, serial increment of cardiac troponin I. Otherwise, we can do cardiac troponin T. And if need arises, we can do cardiac troponin and repeat, and then see for the presence of increments. So the other echocardiography might help in ruling the other conditions and to see for complication. But this is bedside echo should be done if it's available, but it should not delay actually the intervention of acute coronary syndrome, particularly STEMI. Angiography, particularly for ruling out the other differential diagnosis. Otherwise, in patient with acute coronary syndrome, the role of CT angiography, if patients are complaining chest pain, usually studies have shown there is no it doesn't have a value in decreasing the hospital stay or in reducing mortality, because usually tachycardia and the likes are there. The common trials, Beacon, Romicat, Rapid, CCT angiography has shown there is no benefit of CT angiography in acute cases, not in chronic cases. So the same thing, okay? Pass. You can pass. Yes, you can pass. You can pass this one. So MRI, ideally for some situations, but ideally they are not. For, like, if there is a difficulty of echo view, otherwise they in acute ways they are not much as such useful. So management of patient with acute coronary syndrome, it depends on what we have, depending on the ECG finding, ST segment elevation and non-ST segment elevation. So there should be ECG, as we have said, within 10 minutes, and defibrillator should be accessible, and all patients should be immediately put on ECG monitoring. And depending on the finding, we need to subject patients to different management protocol for STEMI and non-STEMI patients. So you can pause next. So particularly patient with STEMI should that's why we are emphasizing patients with STEMI have high risk of mortality in acute and in the long term. So we need to able to identify, and ideally patients should be transported to PCI capable setup. But in our setup, if possible, fibrinolytics should be given if time allows and the patient situation condition allows. So ideally, I think in the future probably we'll go into that area, because now we cannot, for most of our patients, despite we know what's the proper management, we are still working. We were treating them as in 90s, 60s, 70s, except the medical therapy. So some conservative management are applied, but ideally, patient with STEMI should be transported within timely into PCI capable environments. In fact, the good thing is nowadays PCI are available in capital cities, so that's a very good news in more than 3 or 4 places. So as you see, STEMI treatments in the earlier 1960s, I mean in 20s, early 20s, STEMI was treated as with clinical recording, but in 1960s, more of arrhythmia treatment were developed. Cardioversion and defibrillator development has changed the mortality and also the treatment of STEMI. Later on, 1970s, some invasive technologies have been introduced. In the early 90s, 80s, the introduction of fibrinolysis, PCI, the birth of PCI has changed the course of STEMI patient. But currently, since in the last decades and a couple of decades, we are using evidence-based coronary phase therapy where reperfusion plus medical management are optimized. In fact, if we even we don't apply to all of our patients, some of the patients who have an opportunity to get reperfusion are benefiting from this evidence-based treatment. Time is very important. Time is for STEMI patient. As we earlier said, it's a complete occlusion of coronary artery. So different biochemical and structural abnormalities will pursue within seconds. So time is very important. So patients should undergo in a proper time, particularly within 100 minutes of PCI possible, but if not possible, fibrinolysis should be applied, should be utilized as soon as possible. So it's very important to create awareness as well as to also audit, but ideally this should be applied in if possible. So when someone presenting with chest pain, so after we do in ideal setup, emergency medical service should be dispatched because patient presenting will delay. So medical dispatch should be there. This is in a very ideal setup where regional PCIs are available, experts are available. So the ambulance are dispatched within 10 minutes. And then depending on where the patients from PCI capable, if PCI capable if the patient can reach to PCI capable within 100 minutes, it's possible to take into PCI. But if not possible, immediately fibrinolytics should be applied. And if not possible, patient fibrinolysis should be applied. But if patient can be transported safely within 120 minutes, PCI is said to be superior. I think in the future, as our economy grows and also medical development improves and care improves, I think we should apply this thing. But in major towns, those who can be available to PCI, I think timely approach patient presentation to the emergency is not advocated because there is a delay from the patient. There should be a national consensus should be made, and there should be an available call with an available ambulance particularly to PCI, and PCI center should also be alerted, and people should be alerted about heart attack, and also the possible management and the timely management should be there. So one of the important thing is so a patient with suspected acute coronary, ideally patient should not go into an emergency department. once there is a diagnosis of STEMI, patient should bypass emergency department directly to cath lab, and this has shown to improve the survival of the patient and also decreases the time of ischemic time. So I think we need to also practice this kind of approach, particularly for those who have PCI setup. They should try to avoid emergency contacts as much as possible, because triaging and vital signs, these are very important, but for the sake of benefit of patient, emergency bypass should be encouraged, in particularly PCI setup. Next. So the acute phase are, as we have said, antithrombotic, antiplatelet, anticoagulant, plus or minus fibrinolytics, or reperfusion types of the perfusion, depending on the setup allows. And high intensity statin should be started. Pain relief should be depending on the patient's situation. Nitrates, morphine, IV block, IV beta blocker can be applied. Sedation of patient because patients are very anxious, and as necessary, if the patient is desaturating, oxygen can be used, but oxygen supplementation or oxygen, if someone is saturation is greater than 90, it's found to be detrimental or having side. So it's not recommended for someone who is having saturation of greater than 90. Otherwise, if there is desaturation or less than saturation of less than 90, it should be used. Otherwise, universal utilization of oxygen is not recommended. From the detox MI trial has shown that there is reactive oxygen that can be increased in a patient with MI. So unless otherwise patient desaturates, universal application, universal use of oxygen for MI is not recommended. So fibrinolytics in STEMI, this is one of the tools that we will have that can be easily available in our setup. So particularly patient, if they are presenting with less than 12 hours after the onset of chest pain, it has shown it will decrease around 30 days. So fibrinolytics should be administered in the absence of contraindication, irrespective of the age. But for the age greater than 75 years old, half dose of the normal adult should be used, and it should be so the best ideal time for fibrinolytic administration is said to be 3 hours, but as high as like 12 hours can be used for patient with STEMI. So reperfusion STEMI with has decreased mortality over the last 2 or 3 decades. From GC, SK, as you can see, in the streptokinase has been on addition to aspirin and the antiplatelet. Streptokinase has shown in 1986 has shown decreased mortality, and subsequently different fibrinolytics have been used. This fibrin specific, and then subsequently mechanical like PCI has shown significant decrement of mortality, as you can see from the bar graphs. So there are different fibrinolytic that are available, but I think streptokinase is available in our setup. We can use it. Alteplase and tenecteplase particularly, I think we need to, from our society, should encourage tenecteplase because it is very easy for administration, even though there is high risk of intracranial hemorrhage. But in terms of administration, it is very easy. It's a waste-based and one single bolus. I think this should be encouraged to be available in the country for STEMI patients. So some of the contraindications, I think we need to be well aware of the contraindications will be for providing fibrinolytics. I think there's a list of contraindications are there. Some of them are relative, absolute contraindication, like the presence of intracranial hemorrhage at any time T is one of an absolute contraindication. Aortic dissection presence of some non-compressible fracture, and presence of CNS disease with neoplasm or AV malformation. These are some of the absolute contraindications. And relative contraindication like pregnancy, infective endocarditis, peptic ulcers are some of relative contraindications. But everyone should be aware of the specific contraindication in each patient, and they should be try to rule out those contraindication when using these fibrolytics. Otherwise, it is one of the safest drug. Regarding pre-hospital, this is an IDA setup where EMS dispatch is there with a full cocktails of gadgets of medical equipment available and follow-up. So when there is pre-hospital fibrinolysis, has shown mortality, has decreased mortality. So patient, as soon as STEMI diagnosed, so it should not take more than 10 minutes to administer fibrinolysis in an ambulance, then administer them in hospital. So one of the study has shown, STREAM trial has shown that there is a mortality benefits in pre-hospital administration of fibrinolysis. This is when you have an expert, trained, well equipped, and those who are able to try differentiate, try to rule out contraindication for the fibrinolytic administration, and subsequently when to stop. When you have an expert individual in MS, I think you can administer in pre-hospital fibrinolysis. Evidence has shown. So pre-hospital fibrinolysis is almost said to be equivalent to PCI. So as you can see, it's almost comparable. Even fibrinolytics is said to be more important. So as if timely administered, the PCI cannot be reached in timely way. So fibrinolytics is one of the things that should we encourage, particularly in our developing setup where angiography and the PCR cannot be easily available. So role of angiography and the PCR after lytic. So it's recommended to have an angiography within 24 hours. So for even after successful lytic therapy. So we need to know what is a successful lytic therapy. Pain should decrease, and ST segment elevation should decrease by more than 50%. Absence of arrhythmias, like accelerated idioventricular tachycardia is a sign of reperfusion with fibrinolytics. So either when there is a successful or failed lytic therapy, we need to subject patient for angiography, and do PCI should be done if available. For failed one, rescue PCI immediately. So in ideal setup, PCI mechanical reperfusion is better than lytic therapy. But if you have a choice in terms of timely approach to the reperfusion, as we have earlier said, fibrinolytic is equivalent to PCI. But ideally, if possible, PCI is better if you have in someone. So for someone with late presenters, what do we do with STEMI? So the routine immediate invasive angiography and the PCI for patient to present in less than 24 hours, there's no question, as there is a significant clinical benefit in terms of mortality. But there are few data for someone presenting after 12 hours. One of the data showing in fast MI French acute coronary syndrome registry showed that if someone presented with a STEMI after 12 hours, within 48 hours, it has shown that there is a mortality benefits around it decreases mortality significantly 2.1% versus 7%. But beyond 48 hours, patient with STEMI should be treated as chronic coronary syndrome with a medical management, optimization of risk factors, and complication management. And all trial has shown there is no benefit of undergoing invasive angiography immediately for someone presenting after 48 hours. Well, what about for someone STEMI who are not undergoing reperfusion for different reasons? In our setup, I think the most common reason is late presentation. In the rest of the world, extensive coronary artery, which are not amenable for reperfusion. For some reasons, like the presence of comorbidities that avoids the use of contrast, CKD patient or survival patient with limited survival, like presence of advanced cancer, presence of heart failure that precludes the use of contrast, as well as for difficulty of using this patient. They are in distress. So I think the most common is, one is late presentation in our setup. The other one is the absence of setup most of the time. Most of the time, patients usually present after 2 or 3 days. And early diagnosis, the first physician contacts, particularly in usually they may not be early detected, so patient present late. STEMI case in non-PCI center, they should be transported. We definitely said that one. You can pass. So someone with STEMI with cardiogenic shock, what should we do? So immediate coronary angiography is recommended according to European guidelines based on shock trial. Immediate angiography and PCI of infarct-related artery should be done. This is a class 1B. And if coronary anatomy does not allow for PCI, emergency coverage should be done as much as possible. So can we use the fibrinolytics for someone with shock? So fibrinolytics are recommended to be used if there is no contraindications and if there is no mechanical complication, particularly the aneurysm and ventricular septal rupture and the likes. So we can use fibrinolytics in situation where a patient present with STEMI and the cardiogenic shock. It is class 2A. So the use of intra-aortic balloon in a patient with shock, we might use for just transient support of circulatory support when there is a refractory shock after providing inotropes, fluids, and then patient is having continuous shock. We might use balloon pump, but routine applications are contraindicated in patient with acute coronary syndrome with cardiogenic shock. How about in STEMI? Well, we have already said in the presence of a patient with acute coronary syndrome where PCI cannot be done, but most of the time they are not recommended because it takes time to mobilize coverage team. So in terms of successful, unless otherwise there is ready coverage team, they are not much. But otherwise, if there is PCI fails and PCI cannot be applied, coverage is one of the alternative for reperfusion. But in terms of timely reperfusion, it's obvious. Regarding, okay, this is about STEMI, but non-STEMI, as you know, all the managements are the same, but with few difference. In terms of reperfusion, as you know, all patients with non-STEMI, as we have earlier said, it's not a complete occlusion. Most of them have partial occlusion. So depending on the risk stratification, we need to risk stratify patients with non-STEMI, whether they require immediate invasive angiography or early invasive angiography. Previously, the early said to be 48 hours. Now currently it has to be less than 24 hours. Delayed one is invasive angiography after 40 hours, after patient have been stabilized. So depending on very high risk features, the presence of high risk features. High risk features are said to be like hemodynamic instability, patient with heart failure, recurrent ongoing chest pain, and dynamic ECG changes, mechanical complication. These are one of the high-risk features who need to undergo invasive angiography as like patient with STEMI. But those having high-risk features like Grace risk score greater than 140 and patient with confirmed non-STEMI with troponin positive ST segment elevation, transient ST segment elevation are said to benefit from angiography within 24 hours. And those who does not have fulfill those criteria can stay for more than 48 hours, and after stabilized medical management, they can benefit from delayed invasive angiography. So it's very important. So, okay, I think you can pass. We have already summarized this one. You can skip. Skip this one too. So coming to the antithrombotic therapy. So thrombosis is the central pathophysiologic of acute coronary syndrome. So platelet activation, thrombus formation, is a central to acute coronary syndrome. We need to inhibit platelets, but antiplatelets are with a side effect. So bleeding risk should be assessed, and bleeding should be assessed. But ideally, all patients should be started with aspirin, whether an STEMI or STEMI or an injectable sternum, should be started on SA with loading dose, non-coated chewable aspirin should be started. Next. So just this is the bleeding risk by ARC HPR, American Research Consortium high bleeding. So it just there is a major risk and minor risk, and most of them are like presence of hemoglobin, anemia, CKD patient, elderly patient with previous bleeding status, brain. There are different criteria like the Crusade, Acute criteria, but American consortium is said to be one of the unified for patient to assess high bleeding risk. And one of the limitation of ARC HBR is it doesn't include ischemic risk. Some of the ischemic risk features are complex coronary artery disease, diabetic patient, or some of them are overlapping with high risk of bleeding. Next. So integration of bleeding and ischemic risk is very important. The ARC, as we have already said, there is a limiter. It's limited just only focusing on the risk of bleeding, but the other parameters like precise depths try to combine the bleeding risk and ischemic at discharge. So those having greater than 25 are said to be having high bleeding risk. Those less than 25 have no high bleeding risk. But subsequently, in the long term, after 1 year, DAPT combines these two together also, DAPT score. This is calculated at 1 year. Next. So the standard therapy in acute coronary syndrome is dual antiplatelets, ACA with P2Y12 inhibitors. So the standard one is basically prasugrel and ticagrelor. These are the effective antiplatelet P2Y12 inhibitors. After Plato trial and Triton-TIMI trial has shown that they are superior to the other antiplatelet combination ACA and other like clopidogrel. So for standard one, for someone undergoing PCI, prasugrel is preferred for irrespective of PCI. Ticagrelor is preferred. Pre-treatment, this is what we call, we need to know also pre-treatment is not recommended for someone with non-STEMI, and ticagrelor was tested in STEMI, in Atlantic trial in patients that are going PCI. So whether providing ticagrelor along with aspirin or at angiography shown that both in terms of ischemic and bleeding risk, it was said to be similar. The in non-STEMI, ACOS trial has shown, and ISA-REACT has shown non-STEMI patients should not be treated with P2Y12 inhibitors without knowing coronary anatomy. So that's why European Society of Cardiology puts us as a class 3 or contraindicated to be avoided before anatomy is known for someone who is going to undergo immediate and as well as early angiography for non-STEMI. It's not recommended to start the one which is available in clopidogrel in our setup. It's not recommended to start clopidogrel along with aspirin as soon as diagnosis of STEMI and non-STEMI is made, because we don't know, this patient might have a complex anatomy for angiography, so they might undergo CABG, so it will delay until we discontinue and bled washout of P2Y12 inhibitors. So pre-treatment for non-STEMI, P2Y12 is class 3, but for someone with STEMI, we might consider as class 2B. It's better to give them in cath lab than before cath lab, even for PCI patients. DAPT, we obviously know there is adjuvant effect. The benefit of DAPT in PCI managed from placebo trials and decreased ischemic events, but it's associated with increased risk of bleeding risk. So initially it was clopidogrel. Subsequently, as we have earlier said, Plato and Triton-TIMI has shown they are superior in terms of reducing ischemic event at the risk of bleeding. So standard antiplatelets for patient with ACS is 12 months. But subsequently, there is an interest of reducing antiplatelets as because of the risk of increased hemorrhage. There are a lot of studies that we are going to see subsequently. Monotherapy with P2Y12 inhibitor have been one of the interest area nowadays. So there is at the same time the balancing of ischemic and bleeding is one of the concerning for someone treating acute coronary syndrome, whether someone who undergone PCI or not. So the other one is, so this is the common challenge we encounter. Shall we prevent, when we prevent ischemic events, there is a risk of also hemorrhage. So a balance of the two is one of the things that we need to take into consideration. So we look subsequently some of the studies which encourages the monotherapy and what are their limitations. Next. So shortening DAPT is one of the emerging interesting area nowadays. TILI, TICO, STOP DAPT2, Master DAPT, Global, Host Exam, and so many trials have been conducted. Next, with the risk with the intention of reducing bleeding risk without compromising ischemic events. So global leaders who involved over 15,000 of over 15,000 of patients. Most of them are stable patient coronary artery disease. So they have tried ticagrelor after 1 month of DAPT. They have shown that there is no significant ischemic that's incurred, but there was a significant hemorrhagic reduction. The same thing with the TILIs, which have involved also non-STEMI, most of them after 3 months of ticagrelor monotherapy compared with the standard 12 months of double in antiplatelets. There is no significant in terms of ischemic, but there is a significant hemorrhagic reduction. And at the same time, TICO, which was conducted in Asia, and the TPAS, similar effect have been seen. So the interest from the previous one, double abbreviation of double antiplatelets to reduce risk of hemorrhage after 1 month 3 months have been tried and different findings have been said, but most of them have been studied in the same area like Far East Asian, Japan, Korea, where Chinese. These were done in limited area of the mid areas. So switching, the other one is switching from potents. We have seen Plato and Triton team have shown there is a significant ischemic risk reduction at the cost of bleeding. Now, can we switch from potents, prasugrel to ticagrelor to clopidogrel? Yes, possible. But yes, it is possible, but at the risk of ischemic, also there is some risk of ischemic. So shortening of DAPT duration, there is a growing interest, shortening of DAPT, continuation with P2Y12 monotherapy, but there is a concerning that arise from stop DAPT to SS. It has shown this patient has increased incidence of acute myocardial infarction, even though the rest of the others didn't show that. Stop DAP2 has shown it has involved more than 4,000 patients. And there was an interest from different guidelines following the previous trials that was conducted in Far East Asians. So there was a consideration of shortening to double antiplatelets. So what are the limitations of the most of them trials? As I have said, most of them have avoided high-risk patients. Like STEMI patients have been avoided, and most of them were non-STEMI and coronary, the chronic coronary disease were included. And they were done only in specific areas like South Korea and China, as we have earlier said. Okay, next. Stop. Okay, next. I think I've already said this one. Next. Next. Sorry, next. So stop DAP2 is one of the things that has given an alert, which shows there is an increased risk of acute coronary syndrome, even though the interest was so some evidence has shown positive, but stop DAP2 was really one of things that have alerted. It's no time to do dual abbreviation of dual antiplatelets. So bleeding risk is already definitely reduced. Next, I think, open, next. So is that possible to consider P2 inhibitor from the outset as a monotherapy? And one of the Courage trial, Stop DAP3 trial have been conducted in Chinese, and it shows there is increased risk of thrombosis and unplanned revascularization. Also, it's not recommended to start the monotherapy with P2Y12 inhibitors. What about the addition of colchicine? No inflammatory processes, as you know, it's one of the central in atherosclerosis development and atherosclerotic dynamic changes and in acute coronary syndromes. Colchicine is one of the area nowadays which gets attention. So it is possible to add colchicine if the other risk factors are managed. So what is the standard? No, after we have talked about this dual antiplatelets. So European Society of European Society of Cardiology guideline acute coronary syndrome 2023 recommends dual antiplatelets for 12 months unless otherwise the patient have high bleeding risk. So it's a class 1A recommendation, but American College of Cardiology recently tried to revise it, but the European sticks to a dual antiplatelet as a standard as a 12 months. But if there are situations, it should be considered after 3 months to 6 months. It's a class, like shortening that might be considered after 3 months to 6 months. It's a class 2A. Next. Irrespective of the strategy, ticagrelor is the preferred. We don't have ticagrelor unless otherwise some patient bring from outside. So clopidogrel is the one that we have in our setup. Summary to the alternative 12 months antiplatelets. The decision to shorten DAPT duration to 1 or 3 or months should be taken into consideration of bleeding risk and ischemic risk very seriously. Most of trials are really are designed to detect bleeding risk. They were not much powered to detect ischemic events, so we should not be tempted to use them as our reference, unless otherwise the patient have high risk of bleeding. So they are very selected. They were studied in a very limited area in Far East Asian countries. So it's a very important to take into consideration such limitations. So monotherapy is an essay for different reasons. Platelet activation is lesser in monotherapy. So we might, these are some of the evidence. I think you can pass. Skip next. So some of the ongoing trials, I think these are the ongoing trials that are going to solve our about issue of shortening DAPT. So the compare STEMI 1 ultimate DAPT are the undergoing it is undergoing trials. Next. 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 Next.
ሄሎ አቶ ጌትነት አይታይም ስላይድ
አይታይም?
አሁን አይታይም።
አቶ ጌትነት can you do next please? I think he lost it.
Okay. አቶ ጌትነት
I'm almost through, just left with few of.
Then continue, I think, with the discussion. Without slides.
Yeah. Yes.
We don't have it.
It's not visible, right?
ይቅርታ ዲስኮኔክት አድርጎብኝ።
እሺ.
Do we have time, I think?
Yeah, regarding anticoagulation, the standard anticoagulations are fractionated heparin for patient with STEMI. So shifting from unfractionated heparin to enoxaparin is not recommended. So if you encounter a patient, then patient is going to undergo revascularization, we need to start him on heparin and fractionated heparin. Fortunately, it is one of the most common available, and it is one of the standard for STEMI patient. But if patient is not undergoing non-STEMI patient, we can start enoxaparin, okay? But fondaparinux is not available in our setup. So if you start in fondaparinux and the patient is going to go under PCI or invasive angiography, it's associated with stent thrombosis. So we should not start in fondaparinux. Otherwise, we should add other anticoagulants. Okay, so the other common scenario that we encounter with acute coronary syndrome is patient on anticoagulants. So anticoagulants, it's not recommended to stop anticoagulants. We can start dual antiplatelet, but the period of triple antithrombotic treatment is basically limited to 1 week. And if they are undergoing angiography, INR, we can use other different mechanism like radial approach and likes can be used. Otherwise, for someone already on NOAC, irrespective of the time of NOAC taken, heparin should be added. And regarding continuation of antithrombotic more than 12 months, COMPASS trial, DAPT trial, and the Pegasus trial has shown us we can continue dual antiplatelet in the presence of high risk of ischemic by calculating DAPT score. If it is greater than 2, we can continue dual antiplatelets. I think, yes, jump this. You can skip it. You can again, yes. Skip again. So I think just one slide back. So LDL, yes, definitely LDL high intensity study should be started with the intention of reducing more than 50% of LDL. If someone have been on statin for previously, and if it's moderate or low intensity, we need to start with high intensity. And the target of our LDL should be in acute coronary syndrome, it has to be less than 55. But if you
Sorry, Dr. Damo, we can't see the PowerPoint at getting it.
okay, it's visible to me. I don't know.
Till then, you can continue Dr. Damo.
All
Till
right.
Dr. get it figured out.
Yeah. Okay. Next. Next. So the LDL target has to be less than 50. So it's safer to add ezetimibe or PCSK9 from improved trial. Ezetimibe Odyssey trial has shown as early as 1 month of alirocumab carfilzartan in patients with acute coronary syndrome. So the target of LDL should be less than 55. But if there is a recurrent occurrence of atherosclerotic events, LDL of less than 40 can be as a target. So it's safer to go as low as 20 from Odyssey, and Odyssey trials have shown that. So regarding beta blocker, we can start beta blocker. Most of the beta blocker trial have been done in pre-reperfusion area, so we can start beta blockers. But how long we should continue beta blockers, in particularly in preserved LV functions, are not known. The previous study where beta blocker was given for 2 to 3 months, we know beta blocker, if someone has LV dysfunction, it is have mortality benefits. So there are ongoing studies that tell us about how long we can continue beta blocker. There are some studies showing it's safer to discontinue beta blocker after 1 year, but I think this is very premature, and we need to continue in the presence of LV dysfunction. Beta blocker should be continued for indefinite time. SGLT2 inhibitors in post-MI, empagliflozin in AMI trial has shown there is a reduced BNP, and with also good echo parameters. LV diameter can be improvised with use of empagliflozin. So maybe if the patient are diabetic post MI, we can use empagliflozin safely. I think you can jump this one. So finally, the most important thing is now we have all evidences to treat what is the best for the patient, but the patient perspective is very important, and we need to involve the patient decision in every aspect of the management. I think the right and autonomy of the patient should be respected, and the best, even though even the best equipment and the best treatment are available, if the patient cannot denies the treatment. I mean, particularly this is encountered. I have encountered in Black Lion patient with a STEMI who denied PCI. So it is possible. We need to respect the patient autonomy, even though, yeah. Summary. When coming to the summary, so it's very important to have high index of suspicions. I have encountered a lot of patients with epigastric pain, female patient who is being treated as dyspepsia, but later on turned out to be MI. So I think junior doctors particularly should have high index of suspicion for MI, particularly elderly women and diabetic patient, elderly having atypical type of chest pain, or even epigastric pain, dyspepsia should be taken into consideration. STEMI and the STEMI equivalent ECG finding should be also familiar, and if there is a concern, early consultation is also very important to someone who's senior around. It's very important to to salvage and decrease the mortality of such patients. Next, Togatinit. Next. Yes, next. I think there is a yeah. I think I'm almost through. I know I took a long time, but I'm almost through. Thank you very much, Dr. Kafalany. I take longer time. Thank you. Thank you, audience.
Thank you, Dr. Demo. I think it is because it's a very important topic. I can say in one of the cardiovascular service, especially in emergency, SS will come top. So I think that's why we allow the time. It is also becoming our big headache. It is very summarized to the patient, practical. It will help a lot, most of us. So I will thank you that, as I said, you can the man to present this. Thank you for that demo. And having said this, I couldn't go through what you have done. It has been well summarized. Just to summarize it, I think our main issue is society advocacy. What is chest pain? Where to go? When to come? And the emergency medical service team. Do we have really or central ambulance existing, and what's chest pain? Our physicians and the public should understand, and we have to do from with the society as well, especially our society and the emergency physician societies we should have done more a lot. So it's more of we have been said ECG should have been seen. That was discussed in detail by Dr. Demo. So maybe in the near future we'll have a hub to have ECG in one center by our society from every corner of the world, Ethiopia. Somebody can send the ECG, will interpret, then send back, maybe advise with management. That will help a lot. And issue of thrombolytics, we have been discussing with high authorities to have at least kinase vital in the country. Maybe tentatively is very expensive, so in our society, let's have at least kinase. Then we have some PCI centers that should be utilized actually. The man who reached one time and can afford should be pushed on that. Even if I not afford, we have to push because he's losing his heart muscle. So we have some few centers in Addis. Out of Addis may not reach in the golden time. So in those patients, I think we have to capitalize thrombolytics are important. So diagnosis, STEMI, if possible, PCI, if not thrombolytics. So the rest have been said very nicely. I cannot go through that. There are till then, I think Mr. Getinat, you can share the link of the queues, and there are a few questions for you. First question was by Dr. Gardisa. What does mean 99 percentile of high sensitive troponin? Is that the high cutoff of specific lab, or what does that mean? This is question one. Another question is Dr. Ayalio. I think he's an emergency. He's doing a lot, I know. So I think we should do with emergency physician and our society. This is an emergency, really. How do you see in our country emergency medical service, such as ambulance, the trained paramedicals? How do you see that? And how are you practicing PCI in those who have sudden cardiac arrest survival? How common we are doing that? And this is question number 2. Question number 3, Dr. Sir Callum, if not mistaken. Can we give DAPT in lower dose, especially those who have high risk and low body weight? Can we decrease the dose of DAPT? This is question number 3. And question number 4, Dr. Malaku, what are the criteria? You have mentioned this, I think. What are the criteria to discontinue DAPT prior to 12 months? Just to mention a few criteria. These are the questions entertained through the chat box. Maybe we'll have a chance to give them with the mic by Mr. Getinat. Thank you, Damo. So this question for you, and I will discuss.
Thank you very much, Dr. Kafale. And yeah, 99th percentile is basically it was this was sampling was done from normal populations. So troponin basically can be seen in a normal population. This was done like uh, like uh, 30 years or probably 20, 30 years back in one of British. One of the what I remember was it was sampled from a normal population who doesn't complain about chest pain. So the cutoff point troponin, it was around 40 nanogram. I mean, most of them was 40 nanogram. So as I've earlier said, troponin can be found in a normal person. So the cutoff point for 99% of normal person without chest pain can have a troponin as high as like 40s. So depending on the assay. So the cutoff point for 99, as you know, most of them, it's from most of the biometric that we use is a blood pressure study from normal population, weight from normal population, whatever blood sugar from normal population. So the same thing is true for troponin. Troponin can be secreted, can be available, can be seen in blood serum in a normal person. So beyond that, so if it is found to be beyond that, the cutoff point was put forward by uh, revised by even high sensitivity troponin you can find in most of persons. Even leave alone the convention, leave alone the high sensitive conventional can be found in a normal person. So the cutoff point have been taken up from normal person. So those having beyond that are said to have ischemia with not only troponin, but we need to combine with clinical situation. So the cutoff point has been set from sampling from a normal population. But we don't have what is a normal percentile, 99 percentile in our setup. So we don't have our population sampling from a normal person. So we use basically that have been taken from the Western side, which was done like a long time, 30 of 20 years back. So I think we need to probably this is one of the area that we need to know what is a normal troponin in a normal person in our setup. So what is a normal cutoff point should be known probably if we are capable to do that. But the cutoff point is understanding it's to mean beyond the 99 percentile. So if it is beyond that, it's to be abnormal. So most of nanogram is the one which you use, 40 nanogram per liter. So regarding Dr. Ayalo, I think emergency medicine, it's a newly introduced in our in Ethiopia. I think they are doing wonderful job, particularly in hospital-based emergency service are now they are almost available in majority of Addis Ababa hospitals and some of referral hospitals in the regional hospital. They are doing wonderful job in terms of managing emergency situation. Where I think acute coronary syndrome is one of the things that is encountered. I think we need to work actually capacity building together as well. Emergency AMS, I think dispatch, I don't know, I'm not sure how common the emergency dispatch is available for someone who have chest pain or any other condition, sending ambulance. It's not much very common. Actually, those who can afford, those who can do, they're well-to-do people can afford to even order emergency helicopters. But I know in this country, but emergency ambulance, it's not common, particularly for chest pain. I think we need as society, we need to encourage, we need to create public awareness, and the Ministry of Health and the Regional Health Bureau should be mm, uh, sensitized about these issues and how to coordinate particularly PCI center with the PCI centers, and then how to early detect acute coronary syndrome, and then emergency management should be we need to do better, I think. Otherwise, if you are asking me about emergency service, I think they are doing wonderful jobs. Regarding the post-sudden cardiac death, sudden cardiac arrest. So if it is so PCI angiography can be done particularly if someone is conscious, is post-cardiac arrest with not immediately, but if there is an ongoing ischemia, it's said to be angiography, invasive angiography should be done as soon as possible. But if they are do not have any clinical ongoing evidence of ischemia, they may not they can be stabilized medically, and then PCI as time as appropriate as condition allows, they can be undergo angiography. So sudden cardiac arrest, if it is presumed to be of ischemic origin, I think they should undergo coronary angiography, and PCI should be done. But we need to rule out whether this is really caused the sudden cardiac arrest is MI, or maybe arrhythmia of second other causes, hypertrophic cardiomyopathy or other ventricular tachycardia. It depends on the patient conditions. Regarding, we might consider about DAPTs with low body weight, but the standard recommendation for there are standard recommendation, ticagrelors and prasugrels can be considered. But for someone, clopidogrel, as you know, the standard, it ranges from loading dose from 300 to 600. Yeah, but depending on the patient condition, I think we apply 300 most of the time. So the maintenance dose is 75. We don't have less than that. And prasugrels and ticagrelor can be applied depending on the bleeding status of the patient, the high bleeding risk, low body weight. It can be considered. I think the question is for someone, but the studies are basically there is a fixed dose trials, like for ticagrelors, it has 180 by 180 BID or 110. 100 can be applied. And the other issue for criteria to 4 months to discontinue DAPT before 2 months, 12 months is high risk of bleeding, but DAPT abbreviation should not be tried in the first month. And the European Society of Cardiology recommends basically to consider after 3 months if there is no event of ischemia, or there is no high risk features for ischemia, particularly diabetic patient with complex anatomy of PCI, if there are stents, multiple stents are used, and if patient have CKD, high risk of ischemic events, previous history of ischemic events. If they are there, it's not recommended to abbreviate or to shorten the duration of DAPT. But if there is high risk of bleeding or bleeding events, we should abbreviate. The other issue is anticoagulation. I've said if patient requires anticoagulation, triple antithrombotic treatment are basically for only one week. If patient have high risk of the ischemic risk factors, we might prolong to 1 month. Otherwise, after 1 week or 1 month, depending on the patient's situation, with single antiplatelet with oral anticoagulant up to 12 months. After 12 months, all antiplatelets should be discontinued, and the patient should continue with anticoagulation. I think these are some of the questions. I don't know how.
Yes, sir. Yes, Dr. Damo, well addressed. I think there is one last question. It is regarding not ACS. It is issue of digoxin As his question was, I have seen digoxin being used in health center for arrhythmia. What's the current recommendation of digoxin? Digoxin, when it comes to mortality, not okay, but acute coronary syndrome, it has no place. Yes, as for arrhythmia, we'll use that for rate control, and especially we don't have too much antiarrhythmic drugs, so we don't have too much option as well. So for arrhythmia, with preconditions, so of kidney-fine plus M5, we can use both the IV and the PO digoxin in lower dose.
Yes.
And if there are questions with Mike, please, to get in it, you can.
Doctor, it is high time. I don't think we can give mic for others because it is already 20 minutes past the allocated time.
So can we finish the discussion?
Better to summarize it in the wind up. We have already shared the link for the post test.
Okay. I have to take this chance to thank IMA and our society, Ethiopian Cardiac Professional, and especially Dr. Damu for giving us this time and for a busy schedule. And I would like to thank the participants for giving us this very important time of them for this topic. And I would like appreciate to work together, especially for emergency physicians, as Dr. Ayalo said. And thank you very much, Dr. Getinat, for organizing it and pushing us. And I appreciate that. So thank you. We'll work together. Have a nice time.
Thank you very much. Thank you, Dr. Kafaling. Thank you, Ima. Thank you, Ethiopian Society of Cardiology Professionals. Thank you, everyone, participants. Thank you for your feedbacks.
Okay, thank you very much. On behalf of IMA, I also would like to thank Dr. Demo for your time and a very extensive and a very informative presentation. Dr. Kafade for your beautiful moderation, and the participants for your time. And also we will have subsequent webinars. The participants can follow us on our website and social media, and you can join tomorrow and after tomorrow. After March 5, actually we do have 6 more CMEs you can join, and you can share knowledge. Thank you very much. Have a nice night.
Thank you.
Thank you.
Thank you. Hey, we are good.